Hello, my name is Nicholas Marin, and I am one of the Doctorate of Athletic Training students at Indiana State University. And today we're going to be talking about underserved populations in athletic training and how it relates to our setting and our experiences with these populations. Um, I'll send it over to one of my colleagues, Adam Kitchen.
Hi, like Nico said, my name is Adam Kitchen. I'm also one of the DAT students here at Indiana State University, and I'm also a graduate assistant working with the track and field teams at Indiana State.
So I'll go next. My name is Jamie Nickander, also a DAT student, but currently I'm a graduate assistant at Terre Haute South High School.
My name's Dustin Anderson. I'm a DAT student, and I work with the military at Fort Sill, Oklahoma.
And I am Bobby Vallandingham, and I'm also a DAT student at ISU, and I'm the head athletic trainer at West Vigo High School.
Okay, so to start off the conversation, I just kind of wanted, because we got thrown a lot of information, I think, this week on underserved populations and several different kinds of them. So was there anything in the readings that particularly surprised you or really struck you in the readings this week?
I would have to say nothing really struck me too bad. Coming from a low socioeconomic place in southwestern Virginia, working with the military, seeing a wide range of people from the U.S. and different countries and different religious backgrounds, ethnicities, sexual orientations, and everything like that. Like, I feel like the more I read, the more I realized, okay, I've been exposed to quite a bit and have a pretty good understanding of that, and I think from that pretty broad exposure, I've been able to work on some of the biases that I've had, and figure out strategies for that to provide better patient care.
Yeah, I mean, I would agree. I think my clinical setting is a little different than Dustin's as far as the population that I see. I don't normally see a lot of the diverse population that he may see or other people may see, but I mean, being a member of normal society, I can see where a lot of those biases and a lot of that stuff can come out. But I think as far as my personal clinical setting, really the only thing that I really see is low income or poverty type people, and but as far as like race and gender and things like that, I don't normally well, gender obviously, but race, I don't get a whole lot of that, and I can't think of what I'm gonna say. Religious beliefs, don't really see a whole lot of diverse as far as that is concerned either. So my population isn't really diverse as other people's may be.
Yeah, just piggybacking off of what Bobby said, I personally haven't had much experience with diverse populations. Some of the interesting things that I saw was during my undergraduate career while I was observing in an orthopedic clinic with more of a general population rather than a collegiate population or a high school setting. But when I was at the high school setting, yeah, we saw some low socioeconomic status stuff, and obviously that could impact them when it came to referring them, whether it impacted their insurance, things like that. And then when I was at an orthopedic clinic, there were some. What was really opened my eyes a bit was the doctor I was observing had his evaluation was severely impacted because he was trying to evaluate a Muslim woman who had coverings on, and she couldn't expose her skin, and she didn't speak English. She had her daughter with her who spoke broken English, and so that was actually really eye-opening. But personally, I haven't had to deal with or experience any of those struggles, but it was definitely difficult to do an evaluation. So that's some of the readings kind of reminded me of some of those things, and so far the only connection I could have with my population is low socioeconomic status and problems with insurance and some of those other monetary things.
I think the key points that kind of stuck out to me was the fact that there is such a need for general health care and like just knowledge assessment of the people. You know, like, do you know how to take care of yourself? If you don't, we're going to teach you how, or just having access to the healthcare, even if they can pay for it or they have the ability to pay for it. It's like they don't know where to go or how to get it. It's like the basic stuff, you know, like prescription meds and a checkup. And I think the big thing are these clinics that are available, kind of like the one that Dr. Demchek runs, where people can go in and just get seen for the smallest thing because they don't know what's going on with them. They aren't knowledgeable enough in the sense of their own health and their well-being to be able to take care of themselves. And they may be very intelligent people outside of that, but obviously, you know, like medicine is a different thing. Health is a different thing when it comes to treating yourself. So, you know, like some people don't know the difference between ibuprofen and Tylenol and when to take which one. So I think that really stuck out to me in terms of these things where the availability and the need is very high, but to know where to go, I think that's what's lacking.
Yeah, I think those are all really interesting points. I think that in my clinical setting, the most diversity I probably see is with income status. You know, at a high school you get such a wide range of it, and you can definitely see that in the way you interact with patients. But from the readings specifically, I think that I personally was really surprised, and I think that this is just because I feel really personally open to the LGBT community. So I was really surprised to hear that it being LGBT affected income and health status so much. And I think that they talked about the South a lot specifically, and I think because I haven't been there, I think I've been in other communities that are so much more open to it. You don't see how that affects people's health as much, and I think it just made me really sad. So I think that that's just being a little naive just from the backgrounds and communities that I've previously come from. So I think that it'll be really interesting, you know, to try to take that information if I ever work in a place that might not have quite the equality and openness as I previously experienced. But Dustin, it sounded like you kind of had the most personal experiences with some underserved and populations. So can you kind of share with us your experiences working in the military that you've kind of had to work with as a clinician?
Yeah. I'll go back to what Adam sort of touched on a little bit earlier about you know, language. You know, we sort of take it for granted that whoever's going to come in the clinic speaks English. I was at Fort Benning. We were doing some screening, and this trainee was just not getting what I was saying, and he seemed like he was understanding, but for me, like, he wasn't doing what I wanted him to do, and I was getting frustrated. And his, what the Army would call battle buddy, was right beside him, then just started speaking Spanish, and the kid got it. I'm like, oh, okay. I just linked to it. I was like, okay, next time just say you don't speak English, and it's fine. And I was like, you're beside his side when we're talking. I've also had to, you know, use other people going through an evaluation, like a HIP evaluation, that like some female couldn't speak English very well, so had to work through an interpreter to do the evaluation, and, you know, come to find out she had a femoral neck stress fracture. But I've got pretty lucky having people there that speak other languages. I've had to work through Spanish, Korean, and Russian, so I've had to use interpreters for like 3 of those. And one of my coworkers at Fort Benning, there was a trainee from China, and the drill sergeants didn't speak Mandarin, and he got stuck on the tower. So my coworker spoke Mandarin and had to sort of talk him down from the tower. As far as experiences with different religions, when I was at Fort Benning, there was an Abolic student. He was Muslim, and he was going through Ramadan. And the drill sergeant, the cadre was like, what do we do? I'm like, well, I guess till the sun goes down. It's pretty hot summer in Georgia. I was like, make sure that he's not doing nothing too intensely, and you're keeping an eye on him. And when the sun goes down, he's eating and drinking. But definitely for his safety, you might need to draw back the activity a little bit. And the other one that comes to mind was we had a OCS student. She was a very conservative. She was practicing a conservative form of Judaism, so she just had a straight kosher diet. And if you've ever looked at the food in the Army DFAC, it's sort of like their cafeteria. It's not very kosher. So sort of having to do research on like what can she eat, what can't she eat, because she was a small female, and you can't. The military does a good job of not denying anybody their religious beliefs or what they would like to practice. So it was just working around that. And I worked with some cadre that had been deployed overseas, and they say like if they're working with like a foreign force, and most of them nowadays have been Muslim. If it's Ramadan, they can actually sort of get an exception if they're in a war zone because they're there for defense. But we won't see that in athletic training. But there's I don't want to say a way around it, but there's exceptions for everything. And I think when it comes into like their health and safety, that would definitely be one with that.
Yeah, that's good to hear that, because that's what I was going to ask originally was, how open was the military to you needing to make those modifications for your patients, and so that's good that there's that support system. So, it kind of brings up the religious point. I think a lot of our readings and presentation this week's kind of brought up asking the question like, why do you think this is happening to you, or why do you think that you're ill, to kind of bring up a lot of patients who believe that their health might be in God's hands, or even the example brought up that the baseball player thought there was a voodoo on his baseball bat. But these are things our patients truly believe in. So if you had a patient who discussed that belief with you, like, how do you guys think that you might approach their care differently? What resources would you use? How do you think you might be prepared to handle that type of situation?
I think the number one thing is to just be open-minded about everything. Walking in as a blank slate when you're trying to treat someone, I think, is really important, because obviously everyone is different. Everyone is coming from a different background, especially with backgrounds that we aren't familiar with. Being able to just keep an open mind and be aware and cognizant of our own biases when it comes to personal beliefs, religious beliefs, how we see medicine versus how somebody else sees medicine, or their perception of medicine. Because even in my population, it can be difficult talking to them about what their perception of anything is, because they'll have wildly different ideas of what research says, but they don't know that. And so even trying to explain simple things to a population in the United States college setting, it can be difficult. So it can be I'm sure it can be even more difficult trying to communicate with people across different cultures and beliefs, like Dustin was talking about, especially with different languages. That's got to be quite a challenge. And I mean, I've only seen that once, and we've had obviously in college you can have quite a few or a small amount of foreign exchange students that are competing, and we have some at Indiana State here, and most of them do. I mean, they do speak English, but sometimes it is a little bit more difficult to communicate with them. But back to my first point, I think just staying open about it and not trying to get frustrated, not getting frustrated with somebody when they're either not understanding what you're saying, or if you think that their beliefs don't align with yours.
Yeah, and I might have to agree with the point that you make of just being open-minded of what could be going on and how you could best serve the individual. And if we take into account that we create that safe space for the individual to come in and get health care, it should be a place where they're aren't any stigmas, there aren't any, you know, anything that's going to inhibit them from getting the care that they need directly from the healthcare provider that they're going to. And I think back to what Jamie was talking about before, especially with like the LGBT population, and with any population really, it's kind of like we don't really notice that there's a stigma unless it's obviously brought up upon, you know. So let's just say like, you know, like any minority or um, any religious faction where you're going to have that thought in your head, kind of like what Dr. Games was talking about in the synchronous session this week. You kind of have that thought in your head like, oh, I know that this person is different, but I'm not going to treat them any differently, but this is how it is, you know. So like there's this invisible thing that you aren't really seeing, but in your mind it's happening anyway. And that's the hard part in trying to block that. And, you know, like, everybody has their own way of looking at other people or looking at the world, and in general, the stigma is always going to be there. But the fact is, you have to kind of like fight it and fight through it, and that's kind of like where the being open-minded and being open to the individual or whoever they are, and noticing that, like, even if it's someone that you aren't directly like doing anything to, there's still a stigma against them, so they're going to come in with their walls up. They're going to come in with, I feel like I'm probably going to get treated differently because of this, especially in terms of HIV, you know, like AIDS, anything like that, where even if the individual isn't homosexual or transgender or anything, the automatic stigma is, oh, well, they probably something, you know, anything could have happened, or, you know, sometimes that even just happens where you're born with it because your family member got it before, you know. So I think that's one of the big things, especially in athletic training or athletics and anywhere we deal with bloodborne pathogens. It's like a big thing, and I've actually had experience here currently with the drum corps. We have a member who is HIV positive, wrote it on their form, we talked to them and everything, and then the director was just like, what do we do? Like, we have to do something, right? We have to. I felt like she wanted to put him in a box or something. And I was like, no, we don't have to do anything. Just we give him his own little med kit, and if something happens, he cleans it up and makes sure nobody touches it, and then tells us about it, and then we take care of it. You know, like it's not a big deal. And you know, those people take medication anyway. And then if you do get exposed, you can take an automatic like plan pill that basically kills everything before anything starts, because it's so weak in terms of how it works. So there is always a plan for that, but it's like the concept that stigma is already there, and it's like, what do we do? How do we protect everybody else? I'm like, what about the individual who is here getting care? You know, like I think that's the thing that we need to focus on. It's like, yes, maybe there is that concept of we need to protect other people, but we also need to remember that the individual is there. They could be psychologically traumatized from their injury, and not only just the health problems that they have originally. So I know I went on a tangent there, but does anybody have experience with like any sort of thing like that with like BBP, even if it's not LGBT, but like with minorities? Because I know it's prevalent in all populations.
No, I don't. I don't necessarily think I have any experience with dealing with that kind of stuff. But another point that I wanted to kind of bring up, and we can go back and touch on that point if somebody else has a something to talk about on that point. But another point I wanted to bring up was we got to kind of think about when we talk about people that we go to for advice or whatever in these sort of situations. We have to think about who we're actually going to talk to. So maybe if I had somebody come into my athletic training room who had some sort of religious belief, and maybe I would talk to their parents about it, maybe try to get some insight that way. But what if their parents have a different religious belief? So I'm not going to really get anything out of them, or might create a hostile environment, bringing in a parent who may try to talk them out of whatever they're trying to do. And maybe the college setting where you usually don't talk to their parents, so you have to have somebody else that you can go to deal with that sort of situation. And maybe you just, like Nico said, maybe try to get through it, talk to them, talk through it, see what their belief is, why they believe this way, and then maybe go home and do your research on that specific religion, and maybe get some ideas that way, or maybe try to find a way around their religious beliefs so you can still provide the care that you need to without invoking on their religious belief or something like that. So we got to think about who we talk to in these situations and try not to start a hostile environment by talking to people that we shouldn't be talking to.
Sort of to piggyback off that, Bobby, when I was at OCS, I worked really closely with the chaplain there, and the chaplain was Buddhist, so it was pretty interesting to talk to him. So if I would go out to a training event, say like land navigation, like FTX related, their field exercises, and somebody was hurt, my rationale was it's hard for me to say it's going to be okay when I just told them, hey, this is what's going on, this is where you're going. So me and him teamed up, and we worked pretty well together. Like, he would go out there and to see how everybody was, and if I needed them, I had the option to ask that person, like, hey, do you want to talk to the chaplain about what's going on? And if they said no, we just moved on. If they said yes, I would go get the chaplain, and they would talk for a little bit. So it was pretty good, and it was pretty interesting to see how that worked.
Yeah, I think that's a really cool resource to have, and I think, based on my original question, and everyone's kind of getting to that basic point, is just to be able to have an open dialogue. I think it's important for us to be interested. I feel like a patient's going to open up to you a lot more if you seem sincerely interested. I think even I had a patient recently who didn't believe in taking NSAIDs, painkillers. Like, she just didn't take medication. And I think, granted, if she had like a very serious condition, she might, but as far as like taking it for pain, she wasn't going to do it. And this was a high schooler, and that's just what she chose to do. And there was a lot of people, like even her coach came in and said, oh, like, you have shin splints, why don't you take something for it? And she had to like stand up and tell them, so everyone expected her to do something that she didn't want to do. And so I was just really intrigued to ask her, why she made that decision. And so I think that built a really good relationship with her. So I think that that's a really important thing, is to just honestly care about it and to portray that. But what was interesting to me, kind of based off your story, Nico, what comes up is I think us as clinicians might do a better job of being open-minded about these things, but it kind of made me feel like how much education for coaches and stakeholders are we going to have to do if we have someone with religious beliefs. So your coaches are going to expect you after so long to treat ankle sprains a certain way, or they kind of know your protocol, they know what you're going to do. Well, when you're not doing it for a particular person and they think that's what's going to get them better, like, why are we not icing this person, or why are we not doing this? You're going to have to educate the coaches on these religious beliefs as well. And so I think that's where the stigma comes from, and I think it would be a really interesting process I've never had to do it personally, to see kind of the reaction of coaches if you're not providing the typical medical care that you might provide to somebody else, how they're going to treat that athlete after that would be interesting to see.
It's sort of, oh, sorry, Nico.
No, you're good. So the concept where you have the religious belief, that reminds me, I was assigned to a high school in undergrad, and two of the high school students who were on the field hockey team wore burqas. And for whatever reason, we were at like a championship tournament or something bigger than just a regular game, and the referees said everybody on the team has to have the same uniform, and only one person can be dressed differently than everybody else. Like if they're wearing black underneath, or if they're wearing white underneath, or if they have a tank top instead of a shirt, like everybody has to look the same. And since both of these girls were wearing burqas, he said, you both can't play unless one of you takes them off. And I didn't know if the guy didn't know what was going on or something, but then the entire team said, postpone the game, we'll be right back. They all went to Walmart, bought like linen, and came back, and they all wore burqas for the game. So it was great. And it was really cool because like the ref didn't know what to do. The coach stayed. The other coach was totally fine. It was just like the ref was like, I have to follow the rules. So that doesn't really have to do with healthcare. But if we think of that in terms of the sense of like what needs to be done, creating an inclusive environment for the individual, I think that's the key thought there. Even if they are showing up differently than other people, if we treat them as if there's no big deal, and sometimes like I think we also need to think about like it's that weird happy medium gray area where we don't want to treat them like they're invisible, but we also don't want to make it a big deal. We want to make sure that they're included, but then not over-include them to where they stand out. And it's like Jamie said, that education of somewhat, if it's the stakeholder, if it's the staff, that should definitely be something that's incorporated into the healthcare setting.
All right. Sort of going back to what Jamie said about the coaches and things, when I was an undergrad, it was my last semester. I was like, hey, I'll take this coaching and officiating class. I don't know much about officiating with sports, and it turned out it was a coaching ethics class. So it was very interesting to go through that one. If anybody's interested in the book that we used, it was great. I can send that to you. But getting to the point of the story, at the end of the semester, our big grade was interviewing for a job. So we had to get our coaching philosophy, everything else. And the undergrad that I went to was affiliated with the Methodist Church, but it was a very open. It was a liberal arts school, so it's very open with everything. But you have the majority of the students there practice Christianity, and one kid was very straight laced, and he did his interview, and at the end of it, I was like, it sounds like you would probably be best suited working at a Christian school. I was like, if you were in a public school and someone wasn't practicing Christianity or didn't practice religion at all, would they be allowed on your team? And he said no. I was like, at a public school, you can't deny people to participate on a team. He was like, this is what I believe. If they can't get behind that, they're not going to be on my team. I'm like, I don't think you're getting it. I was like, you can't deny people what they believe. And he was just so bullheaded about it. He just wasn't getting it. Like it seemed so foreign to him that if somebody didn't believe what he believed, how couldn't they? Like it was like the facts are there for him. Like if you couldn't get behind what he was saying, because his coaching philosophy was tied directly into scripture and things. Like if you can't get behind that, like you can't be on my team. It was interesting to hear him talk and everything else, and I took something out of that when I left that class, going, okay, what do I do that may make people feel unwelcomed, threatened or anything else like that? Then after that, that's sort of when that internal dialogue sort of started happening, and it's not an easy conversation to have. You just look at yourself in the mirror, it's like, did I treat everybody the same today? If not, who did not treat the same, and why didn't I? And ever since then, it's got better. I still have some days where I'm like, may treat people different to some extent, but it's usually not because of who they are. It's because I'm busy and I'm trying to do something else, and it may come across as I'm treating them different for what they've usually been treated different for. Does that make sense? But it's not nothing in themselves. It's just because I'm busy and I may come across as harsh and rash.
No, I agree. I think I catch myself doing that, spending a little more time on one person or less on one because I got to get out to practice or I got to do this. And later on at night, I'm like, wow, I feel really bad about that. So I think we all kind of experience that. But I think your experience as a student kind of leads me into the next question I have. So how do you guys think, what are some things we can do, or an educational institution can do, like entry-level athletic training program, to develop cultural competency in their students? So how can we expose students to this stuff early on?
some sort of training, some sort of educational training. And I know it's like, oh, we have to put them in another class and such, but if it becomes the norm, if it becomes the concept of underserved populations, which is completely relevant in today's society with healthcare, then it might be integrated into the like the course schedule, some sort of implementation into the program itself, into the requirements and the competencies for that individual to be knowledgeable and educated on the concepts that are around them. And I think it does happen in the sense of when a student goes to a four-year university or college, they get exposed to these types of things, like learning about other religions, cultures, sexual orientations, backgrounds, and then religious views. But um, I think it needs to be forced more onto the person so they get it. Because you can lock yourself in a room and go to classes and that's it. Some people will say that you get experience like that from going to college in general, but I think like in the future, if you guys are like in the Indiana State University area, I know that they're hosting ally training for LGBT education, where you can be an ally to coordinate and be there, like a safe space for anyone to come to you to ask questions. And I really think healthcare providers in general should be those areas for people to be and be able to talk to, because a lot of stigma surrounding LGBT is, disease, and we should be like in the forefront of come to see us first, come to talk to us. We are here for you, and that should be definitely a realm. So check into that. I can send you guys the info on the ally training of when it is and where it is, because I know Indiana State's doing something for that in July, but I'll keep you updated.
Yeah, to answer your question about how to get students more integrated into the cultural competencies, I think just having them exposing them to as much of the diverse community as possible, whether the program that they're in has access to a diverse population, or I think everyone has like a social duty, especially even more so as a medical provider, to just have a baseline of different religions or different beliefs, different how people operate at different socioeconomic levels. Like when Jamie was talking about the whole NSAID thing, I had that happen, and I think when I was at a high school too, and ever since then, like my communication has just changed about some of that stuff, and I realize I'll give people an option, like, yeah, you can take this, or we can do this. Is that something you'd want to do? And if they say no, I'm not into taking medications, then I'm just like, all right, then we'll move on and talk about something else that we can do. And so I think it's also a learning experience. So I think there's only so much you can teach, and then the rest is just a lot of experience with each situation, and you gather that new knowledge as you encounter those different people. But I think there is a baseline that can be established, like with Ramadan. That's obviously a common one. With trying to communicate with people who don't speak your language, or if they have broken English, or people who don't take NSAIDs or don't believe in certain treatments. Like, maybe, I don't know if anybody does this. I feel like it could happen. Like if somebody doesn't believe in having invasive surgeries or something like that would obviously be a problem in sports. Like if somebody needs a labral repair or something like that, and they need surgery to keep playing their sport, and the coach wants to push them to get surgery and stuff, like, well, we can't let that happen, or we can't push people to do it if it's against their religious beliefs. We can educate them as much as we can about the procedures and stuff like that, but ultimately it's their decision. And I think that comes down to just everybody they're the final say, and how they treat their bodies and what they want to do. So yeah, those are my thoughts.
Yeah, I think kind of feeding off of that, in my undergrad, I took a cultural competence class, and I believe most of it was talking more about the different religions. I think that's mainly what we covered was different religions and different beliefs that they may have. Um, I think one thing is there's no way I'm going to remember everything about every religion um, in my clinical practice. I mean, I know about my religion, but when it comes to every little belief and things like that for every religion, that's, I mean, very difficult to do. And so maybe you have like a cheat sheet of different religions and maybe some of the more common ones or more common beliefs that you can go look up if you have something like that um, present itself in your clinical practice. And I think another thing is you can take as many classes as you want, but until you actually get in and see those things in your clinical practice or in your everyday surroundings, you're not going to get that. You're not going to really understand the how hard it is to interact with a situation like that. And I'm kind of in that same boat. I haven't really had those difficult situations as far as different beliefs or coming across a difficult situation in that manner. So I just think it comes down to being in that situation and having to experience it and learning from it and knowing how to deal with a situation like that moving forward.
Um, I think that there is something we can do educationally to kind of in the middle ground. So there's the classroom, we can learn about it, and then there's clinical practice, figuring it out as you go. But, you know, they talked about just having like dark-skinned CPR dummies, and that just kind of, that was like the basic, like that seemed like such a silly thing to bring up. Like, yeah, why don't we? But we don't. Like, I've never seen one, and that just seems so silly. And then it started to make me think about like how many case studies did you have to read in undergrad where you were trying to, all you had to do was pick out an intervention where it said Johnny so and so is a baseball player, he has elbow pain. Well, what if we started to include the fact that they are African American, or that they are poor, or that they don't have health insurance, or that they are lesbian, gay, or bisexual? So what if we started to just include those minor details in the million, you know, case studies we read in undergrad? And then to me, the biggest thing to bridge that gap was standardized patients. Like that, just like when I was doing the reading this week, it just like exploded in my mind, like of all the possibilities for that. And I think on our last DAT weekend, we did an SP where I had to work with someone in the military, and it was super eye-opening for me. Like if you would have told me, hey, I'm gonna go evaluate someone in the military, I'd been like, okay, yeah, cool, whatever. And then I got in there and I was like, I have no idea what to ask. Like when it came to what his like training expectations were, who I would have to talk to, like what it would mean to limit his, you know, what he should be doing, I had no idea what that meant for that patient. And I realized instead of just saying that to him, like, hey, I have no idea, will you tell me? I like tiptoed around it because I was uncomfortable, and that was really eye-opening for me. I was like, oh crap, like that was probably my worst SP. I felt I did the worst job doing patient-centered care simply because I was uncomfortable, because I just didn't know. Not because I didn't care, but I just didn't know. And so I wonder, as much as I can sit here and say like, hey, I'm prepared to do that if someone had a different religious belief, would I do the same thing? Would I be uncomfortable looking at someone and saying, I have no idea what this means for you, so will you tell me? And so I think you have to be willing to tell somebody what you don't know. But I really do think that standardized patients, if we start to include more minorities, more details for underserved populations like income and healthcare coverage in the educational setting, we're going to have people that are better prepared to ask those questions when a real patient arises.
Yeah, I would agree. Like when I first started working with the military, we're just put like on limitations. You can't go throw grenades, or they're putting up weapons to go and hit someone. Like it's pretty. I was actually laughing about that today. I'm like, when I go back, if I work back with athletics again, like it's just going to be, I'm to relearn everything. I think it also goes back to the clinician too. The clinician's got to be open and willing to go through those classes and be willing to take a good critical look at themselves to see, where do I stand with this? Am I willing to change and move forward? Because they're the ones providing the care. They're the ones building that atmosphere of anybody can come in and talk about it, but if they're sort of part of the crowd per se, that person is not going to come in and get the medical care they need, and it's not good. It's not right at all. Um, I think one thing the military does really well, I don't know if I mentioned with this one or not, is like the equal opportunity classes, like the EO classes. They also have the ability to file a complaint. I think, ask your athletes or ask your population, are we making an environment that you feel safe in, that you feel like you can come talk to us in? And some people may not want to hear the answers to those questions, but until you ask those questions and you get that feedback, nothing's going to change, you know? So you just got to be able to ask the hard questions and get the tough answers.
So I think the last thing I kind of wanted to talk about is, all of us as clinicians and hopefully future leaders talking about this, I think is really important. So as far as non-discriminatory policies in an athletic training room or a healthcare facility, if you guys were going to go implement something like that in your current clinical setting or a future one, what do you think kind of athletic trainers' role is in that, or what do you think the most effective or important things for a non-discriminatory policy for athletic training would be? I know, that was a hard question.
Really hard question.
Part of that answer comes back to Nico's point about having like a training session amongst staff, similar to how we would have training for sexual harassment. I mean, we already do that. We have training for harassment, and it would just be another good thing to add because it matters to our patients, and it matters how we treat people, and it helps us reflect on how we're treating people and how we're interacting with our patients. And I think that would be the thing to do, since it would be like a standardized way to disperse information. You could test your staff on using knowledge assessments and be able to standardize it in a way so everybody is accountable for how they behave in the athletic training room, and having just a cultivating good behavior.
And sort of piggyback on Adam's thing is sort of, if you give the athletes the ability to file complaints, if that staff member is just a habitual type person that's not improving their behavior and not cultivating that safe environment, in those meetings, like, hey, this is one of the reasons you may lose your job if you're not willing to sort of get on board with this and provide care for that patient and sort of let your personal beliefs go by the wayside at the door. Sort of like, if you're mad, if you're having a bad day, it stops at that door, because our job is to provide good quality health care for everyone that comes in here, regardless of anything. Yeah, you may lose some friends, burn some bridges, but it'll be necessary if you want to have that type of environment.
One of the thoughts I had, and I think it's been brought up a few times, was realizing that so many medical documents are written at such a high grade level for reading, such a high literacy rate. So I think that's definitely something I would look into changing, because I wonder, like, you think about a PPE, especially like in a college, like those documents, these kids are just, some of them are just turning 18, so it's the first time they're signing these type of documents without their parents. And what if they can't read them? Or really understand what it means for them, especially when you're looking at assumption of risk type of things. Like, those are things that I think we all understand legally that they need to understand. So I think that would be something I personally would want to implement, is low literacy rates, just so that, to make sure that I'm including those people that might have come from different backgrounds. Other things I think would be interesting if I was designing a brand new athletic training room would be gender neutral bathrooms. I know that that's like a hot topic right now, but I think if I was going to build a brand new one, I don't know why I wouldn't choose to do that. So those are just a few of the things I think I talked about. But the things you guys were bringing up, Adam, I think trying to test your clinicians or your colleagues, but I also think patient satisfaction surveys specifically about cultural competency, I think would be a good way to kind of measure, Dustin, what you're saying. If you're going to get a pattern with one clinician who's not doing well, that's a good way to find out, or to really test, not just their knowledge but their ability to apply it. I think patient satisfaction surveys would be a good way to do that as well.
Yeah, I was gonna bring up patient satisfaction surveys, and that's something that I'm looking at doing for my project in the other class, and something I really actually want to implement. And I think adding something like that as far as cultural competence, and even though I don't have that that population, maybe I can find something that's like, maybe I'm talking, I don't know, maybe I'm bringing up different things about other religions, even though it's not towards somebody that has that religion. Maybe I'm talking about that stuff and I shouldn't be talking about it anyways. So that's definitely something that I thought about, adding in patient satisfaction surveys that have a cultural competence section in it. I think that would be very useful, and you can also utilize that to find to look at the other clinicians, and maybe you can find somebody that's not really following the rules and talking about stuff that they shouldn't be talking about and things like that.
All right, I think that was the last formal question I had for you guys. Do you have any other general comments about cultural competency and athletic training? Anything else in the reading that you guys want to talk about today?
I don't.
Okay, well, thank you. I thought that was a really good discussion. I really enjoyed hearing about your guys' personal experiences, and everyone's a little bit different. So thank you.
Yeah, no problem.
All right.